A 51-year-old Caucasian female initially presented to her primary care provider at an outside hospital with sinus congestion, fatigue, abdominal discomfort, and lymphadenopathy. Her peripheral white blood cell count was markedly elevated, 7100/mm3, and her lactate dehydrogenase, LDH, was elevated to 409 IU/L, upper limit of normal equals 226 IU/L. A lymph node biopsy confirmed the diagnosis of MCL. The biopsy was notable for nonblastoid histology and a Ki-67 proliferation index of 60%. A MIPIb score of 8 was calculated, which correlates with high-risk disease. Computed tomography, CT, scan revealed lymph node involvement above and below the diaphragm, and a bone marrow biopsy showed a low level of involvement, consistent with stage 4 disease at initial presentation. The patient was treated with 6 cycles of bendamustine and rituximab, BR, at the outside facility. Post-treatment imaging was consistent with a complete response, CR. The patient was referred to our hospital for autologous stem cell transplant evaluation, but declined and continued treatment with her community oncologist. She was scheduled to begin maintenance rituximab in 2 months, but presented to her oncologist's office with abdominal fullness and right arm pain with numbness prior to initiation of maintenance therapy. A CT scan revealed relapse disease in her omentum with mesenteric and right external iliac lymphadenopathy. An MRI of her spine showed an enhancing lesion at C2, confirming her first CNS relapse. She received 1 dose of bendamustine and 10 days of radiation to the cervical spine lesion with resolution of her symptoms. She received an opinion at UNC after this, and we recommended 4 cycles of alternating R-CHOP, rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone, and RDHAP, rituximab, dexamethasone, high-dose cytarabine, and cisplatin, followed by stem cell transplant evaluation. This regimen was given at an outside hospital, and she achieved a CR. 2 months after completion of R-CHOP/RDHAP, the patient agreed to a transplant evaluation and presented to her transplant physician's office with 2 to 3 weeks of increasing headaches, nausea, vomiting, and mild hearing changes. MRI of the brain revealed post-contrast enhancement of cranial nerves 3 through 12 bilaterally, establishing her second CNS relapse. A lumbar puncture, LP, was performed and CSF flow cytometric analysis confirmed significant involvement by lymphoma, approximately 800 clonal cells/UL. Imaging with positron emission tomography, PET, CT was negative for systemic involvement, Deauville 1. Extrapolating from the primary CNS lymphoma literature, the patient was treated with the regimen RMPV, rituximab, methotrexate, procarbazine, and vincristine. She completed 5 cycles and was found to have a partial response, PR, therefore, she continued for 2 more cycles and achieved a CR, 7 cycles total. Additionally, she received intrathecal chemotherapy consisting of cytarabine, methotrexate, and hydrocortisone once each cycle, and her CSF cleared after 2 treatments. The patient tolerated the treatment well, with her only side effect being peripheral neuropathy that was controlled with gabapentin and reduction in vincristine from 2.4 to 2 mg starting with cycle 2. The patient then received a matched related donor, non-myeloablative allo-SCT. Her conditioning regimen was cyclophosphamide 50 mg/kg/4 on day 6, mesna 75 mg/kg infused over 36 hours starting on day 6, fludarabine 25 mg/m24 on days 6 to 2, and TIB 200 CGY on day 1.9. She remained in complete remission 5 months post-transplant and 9 months from her second CNS relapse. Subsequently, the patient had a third CNS relapse manifesting as a headache and visual disturbance. A brain MRI showed relapse in her left occipital region and left optic nerve, figure 1 ABC. She was initiated on Ibrutinib 560 mg daily and her neurologic symptoms improved within 1 week of therapy. A brain MRI after 5 weeks of therapy showed resolution of her lymphoma in the occipital region, and resolution of the left optic nerve enlargement and enhancement, figure 1 ABC. She has now been on Ibrutinib therapy for 5 months and remains in CR with no neurologic deficits or side effects from therapy. She will remain on Ibrutinib until progression or the development of unmanageable toxicity. Remarkably, it has been over 2 years since her initial MCL diagnosis, and over 1 year since her first CNS relapse.